Thank you very much, Erwin, for the introduction. Indeed, I'm happy to be able to share with you some of the results of the Approach-IS study. And indeed, specifically, we target patient-reported health and its correlates in adults with congenital heart disease from 15 countries. This is a scene that you all know. And sometimes you're fortunate enough to have good news for your patients. You can congratulate them because the tests were negative. Everything is perfectly all right. However, not all patients concur with this. Sometimes, irrespective of these negative tests, patients feel that their entire life is affected by the condition that they have. Within the cardiac arena, this was a kind of trigger to think about the importance of patient-reported health. And indeed, an increased awareness of the importance of measuring patient-reported health has been found over the past years. This resulted in the publication of a position paper from the American Heart Association some years ago, really stressing the importance of measuring patient-reported health and, by extension, patient-reported outcomes. Quality of life is one example of patient-reported outcomes. And this review looked at 40 years of quality of life research in congenital heart disease. And this review nicely illustrated what happened over the past decades with quality of life research. And it shows the exponential growth in articles that have been published over the past 4 decades. This is a nice example, a nice illustration of the interest in patient-reported outcomes. But given or irrespective this increased number of articles that have been published over the decades, there are still a lot of blind spots in our understanding. And one of these blind spots have been nicely described by this article. It's a meta-analysis looking at the association between congenital heart disease complexity and health-related quality of life. And one of the conclusions of this meta-analysis was results from some countries, most notably the Netherlands and Switzerland, seem to be better compared with the US and with Canada, while the expected random fluctuation in results was found for the remaining countries. So it was indicated that some countries were doing better than other ones. But the key question when you read a conclusion like this is this really reflecting true differences in quality of life between the countries? Or is this rather a reflection of different methods that have been used to assess the quality of life? If you look through different glasses, then you will have other perspectives, of course. To find an answer on this issue, we all need to look through the same glasses. And this means that we need international studies that are using the same uniform methodology. And in fact, this is all what Approach-IS stands for. It is the abbreviation of assessment patterns of patient-reported outcomes in adults with congenital heart disease international study. For the sake of this presentation, although Approach-IS is a very comprehensive study, but for the sake of this presentation, we looked at 2 aims. First, we wanted to explore patient-reported health in this international sample of adults with congenital heart disease. And second, to investigate the association between patient characteristics and patient-reported health. As I said, Approach-IS is an international study. It was conducted in 24 centers from 15 countries in 5 continents. Overall, we included more than 4,000 patients. 53% were females, and the median age of the patients was 32 years. Looking at the complexity level of the patients, we could see that 1/4 had a mild heart defect, about half of the patients had a moderately complex heart defect, and another 1/4 had complex heart defects. Since we were looking at patient-reported outcomes, standardized questionnaires are the target or are the method to measure this. But again, to answer the research aims of this study, we only focused on analyzing the SF12 in this abstract. SF12 is an instrument that is measuring self-reported health. 8 health domains are included, and it's the good thing about this instrument is that it allows you to calculate a physical component score and a mental component score. These scores range from 0 to 100, and the higher the score, the better the perceived health status. Regarding patient characteristics, we included sex, age, marital status, educational level, employment status, CHD complexity, and patient-reported NIA class. Let's have a look at the results. If we look at the entire sample that we included, the 4,000 patients, on the physical component scale, you could see a mean score of 77. And on the mental component score, we observed a mean score of 72. This is relatively good if you know that the scores range from 0 to 100. If we break this down, according to the disease complexities, we saw that for the physical component summary, the simple defects had a mean score of 80.3. Moderately complex scores represented the 78 score, and the complex defects had a lower score of 72. So you could see that indeed simple and moderately complex defects are scoring pretty close to each other, and the complex defects had a lower score, but not that big. And the same phenomenon could be observed for the mental component summary. Since this was an international study, we could plot the scores from the different countries in this scheme as well. And here you see that the scores, both on the physical component summary as the mental component summary, was the highest for patients coming from Malta and from Sweden. And the lowest scores were found in patients from France, Taiwan, and India. And of course, you can imagine that the distribution of disease complexity may play a role in putting these countries on this scheme. And that's the reason why we also included disease complexity in multivariable general linear mixed models. This is an analysis technique, a multi-level analysis technique that allows to see what factors on patient level and what factors on country level may have played a role. And we found that the physical component summary was correlated with, or a good physical component summary was correlated with male sex, with a lower age, with a higher level of education. Patients who were job-seeking, unemployed, or disabled had a lower physical functioning, and those who were never married also had a lower physical functioning. This corresponds to a certain extent with a self-reported NIA classification, where a lower functional class, which means a better functional status, also was positively related with a good patient physical functioning. Disease complexity did not play a role. For the mental component summary, this was also associated positively with male sex. Patients who were job-seeking, unemployed, or disabled had a worse mental health. People that were divorced or widowed also had a worse mental health, and the same observation for the NIA assessment was found here, that patients with lower class were doing better. Disease complexity was associated with mental health, but not in the direction that we would expect. Patients with a simple condition had a worse mental health status. If we looked at the contribution of country variance in this matter, we saw that indeed the distribution or the explained variance of country differences varied between 6 and 1.3%, and this is a very small portion of the entire explained variance, which means that patient characteristics play a bigger role than country differences among these patients. Coming to the conclusions of this paper, international variation in patient-reported health is indeed confirmed. Patient-reported health was consistently and independently predicted by the New York Heart Association functional class, not having a job, and age. Disease complexity marginally played a role, and only for mental health, but in the opposite direction that we would expect. Patient characteristics were more explanatory than country differences. And these factors that we have identified can be used to target resources and to identify patients at risk. Of course, Approach IS is the work of a huge number of people, and I would like to thank you for the attention and the Approach IS partners for the contribution to the study. Thank you.
Thank you very much, Dr. Moons. I have to congratulate the investigators for their great achievement to include more than 4,000 patients with congenital heart disease in a prospective study around the globe. Congratulations. Any questions from the audience?